So I want to start by saying that apparently on my last video I was quite miserable. So I'm going to try and smile a lot more today. Anyway, let's get down to business. Thank you for joining us for the Facebook Live. I'm joined today by Carol, by Gordon. Carol's one of our planners, by the way. Gordon, what do you do here? Everything?
Yeah, everything.
Okay, everything. And then, of course, online we've got joined by Paul and Christine, both ex-patients and now happy members of the 21D family. Yes?
Yes.
Yes. Oh, don't.
Definitely.
Come on, say something. Right.
Absolutely.
So the format of this Facebook Live, I'm going to start with some education to give you guys some insight into how we do things here and how much detail we go into. So today we're going to cover the subject of what we do with your data after you come for a full clinical assessment and why that data is so important to come to definitive conclusions about what will and won't work long term. So Gordon has very kindly agreed to share his data set with us. When did we treat you, Gordon?
March last year, 27th of March.
27. You remember the day?
11 a.m.
11 a.m. See, even I didn't remember that. That's terrible. And remind me, how many years before you came here did you know that you had a really big problem and you were struggling?
I'm sure 15 years.
15 years.
Yeah, I think maybe even more.
Maybe even more. You were seeing your own dentist.
Yes.
What were you asking and what was the replies you got?
Well, you can't ask something that you don't really have any knowledge of. So I was just asking what I'm going to do in the future, and I don't think I ever got an answer.
None? Zero answers? You must have got something.
Yeah,
You must have said
the answer. Yeah, I had partial dentures. That was the first thing we've done. But after that was go to our hygienist and clean your teeth every 3 months.
The ones you had left?
Yeah. Yes.
Every 3 months?
Yeah.
Right, okay. And how long did that go on for?
2 or 3 years minimum.
2 or 3 years. Anything get better?
No.
Right. Okay.
No, it went worse because I was losing teeth.
So you
all
still
the
kept
time.
losing even though you were seeing the hygienist? Yeah,
Yes.
this is something we hear a lot, actually. I'll tell you where it comes from. Where it comes from, when I was at university, and we're talking 35 years ago now, right? We didn't have any of the technologies we had available today. We definitely didn't have the diagnostics to the level that you get to use now. Carol's a dentist, by the way, so she really understands what she's looking at. We didn't have this depth of visualization, so we would work to okay, well, if we polish them and if we scrape them, it says there should be some improvement. Couldn't really measure it, and we were like, there was a lot of this going on. Today, we know that there are times when you need to surgically intervene. There are times when you just go, okay, this isn't getting us anywhere. It's not returning us to a stable, functional, manageable state, and we need to try and get there. So then we have our full clinical assessment, which is why we drag you all in, because if you guys could supply us with a CT scan, an intraoral scan, and a face scan, we could probably align all of that and then do it without you turning up. But, we need to get you in. But once we got you in, we did those scans, and this is what we got. So can you put it up, please, Carol? Yeah. Thanks for sharing this, by the way. It's really appreciated.
You're welcome.
So this is the presenting state of Gordon. Where the gaps are is where you had your dentures. Yes?
Yes.
How well did they stay in?
Yeah, they're quite okay. Yeah.
Yeah.
Partial denture.
Was there any moment of the day that you ever forgot you had them in?
No.
Were you permanently playing with them with your tongue?
Yeah.
Right. Okay. That's what I thought. Right side, please, Carol. Okay. So we can clearly see on the right side that this tooth is tilted over like the leaning tarapeza, and it should be upright. That's what happens. When we lose teeth further forward, we've got this phenomenon that happens called mesial drift. So that means all the back teeth are permanently trying to drift towards the center line. Especially when you take teeth out, that accelerates it and they tilt even quicker, and especially when they've got nothing above it to stop them from moving. But this is a slow process in relative terms. This doesn't happen in like a week. This takes years to happen. So the patient doesn't really notice. It's a gradual, slow process. And all the muscles around it, the tongue and the cheek, because it's such a slow process, adapt to the daily new reality of change, which is, you know, less than a tenth of a millimeter every month or a millimeter every month. We don't know. It could be whatever the underlying level of disease is. We can also see that you can only really chew in areas where things don't move. So when you have a denture in and you're chewing, the denture moves upwards or downwards, and then the final contact in whatever doesn't move, which is usually the teeth. Which means the teeth are now taking more force, the teeth that are left are taking more force than the false teeth. So it's a bit like carrying my shopping, but only with these 3 fingers. If I kept lifting the same weight of shopping with these 3 fingers as I used to do with 5, these 3 will end up doing more work, and it could increase the risk of them failing quicker. So if we move round to the front, so I assume, Gordon, looking at this, a lot of your chewing was happening mainly at the front?
Yes.
Right, because that's where you've got the majority of contacts, and you can't kid the brain. The brain will go, right, well, I can't chew in midair, just move it to where I've got teeth left. And usually, people lose their back teeth and go, oh, well, I can't see them. Let's forget about them. And then slowly, the front teeth start being used more and more and more and more. And as they're used more and more, they start being knocked out of plane more. Now, if there's underlying disease, they'll move even quicker. And one of the things that we have to do when we see patients is to recognize where it was in the first place. And it's almost always nowhere near where it is now. So there's going to be these movements that happen. And any of the movements that we plan in will have a direct effect on the lip on the front. So if I move the teeth back, even by a millimeter, you'll feel that your lip has dropped a lot. But it's only a millimeter, because that's how sensitive the inside of the lip is. On the lower, if I move the teeth back, all of a sudden your tongue feels like its space has been taken away, even though the lower teeth have drifted forward over time. I know that when Gordon didn't have his denture, how many times a day did you stick your tongue in that gap?
Yeah, all the time.
Because you can't help it. Because it's a subconscious thing. It's a habit thing. You just learn how to do it. I see people all the time. They sit there and they're playing with their dentures, flicking them up and down, flicking them up and down. It's just something that you just learn to do, and you're not even conscious that you're doing it. Can we move to the left, please, Carol? And then we've got the left side. So we've got these teeth, and you can clearly see that they've sort of tilted and drifted upwards, and the space further back is just getting narrower and narrower. If that is allowed to continue, it will just continue going up and reach that gum area. It's only a question of time. And these are off axis. They're tilted, they're off axis. So really, almost all your chewing, even with the dentures, was at the front. Correct. And front teeth are designed for cutting. They're not designed for chewing. The back teeth are designed for chewing because they're shaped like my fist and they're there to pulverize food. The front teeth are for cutting things. So you are using cutting teeth for chewing, which is a huge amount of force. So then it has a detrimental effect on these teeth, and it's like dominoes. We can then see the gum line, we can see the roots of the teeth are exposed. Now, if we can see the roots of the teeth are exposed, then we've definitely had bone loss. Definitely. Because normally, in a healthy state, the bone will always be 2 millimeters below the gum. In an unhealthy state, it can be 5, 6, 7, 8 millimeters below the gum. These are called gum pockets. They just harbor food because none of your toothbrushes clean vertically, they clean that way. So the active disease front is up here, you're brushing your teeth here, none of this is actually getting out, so you end up seeing the hygienist every 3 months, and God bless them. I like the fact that hygienists can catch people early and stop them from progressive disease, but once you cross a certain point, you've got to do something. So when I was taught, we used to do this thing called periodontal surgery. And what that was opening the gum up, cleaning all the rubbish out, and repositioning that gum higher up to reproduce a 2 millimeter pocket. The problem is people don't like to have teeth where they're that long and the roots are exposed, which are very yellow in color and stain very easily. And I just don't think it's done much anymore. There are people that do them, but I just don't think it's done much anymore. The other way is treating it with implants, and when I was taught, we were always taught that if a patient has periodontal disease, then they're highly likely to have periodontal disease again. In my experience, I've not really seen it if, when you remove the teeth, you also clean away all the diseased bone, and then you only put implants into what you know is healthy to begin with, or the least amount of disease possible that you can work to. So that's what we're looking for and hunting for. We're hunting for the healthy bone. And the other thing is, I did a lot of bone grafting in my early career. Bone grafting in single implants is needed quite a lot because of volume loss, and we need to reproduce the architecture around the natural teeth. In full mouth rehab with our kinds of prosthetics, I know that in 97% of cases from our own stats, and this is from the work we do in here, we don't need bone grafting. It's an additional surgery. I prefer to avoid additional surgery if it can be avoided with something that is at least as predictable, if not more predictable, than doing bone grafting. I mean, if you ask any surgeon in the world, would you prefer to do one surgery on a patient or two surgery on a patient? They'll say, I prefer to do one. Because we don't want that much surgical invasion. We want to try and keep it as simple. Now, granted, sometimes you just can't avoid it, but that number is really small in full mouth rehabilitation. I'm not speaking about single implants in and around existing teeth. That's a different kettle of fish altogether. I'm talking about full mouth rehab, particularly using the prosthetic strategy that we use, where we not just reproduce the tooth, but we also reproduce artificial gums, so that stays really stable the whole life, and we can engineer a cleansing gap on tap. Now, the cleansing gap is the other thing. If you look at natural teeth, they all have natural gaps between them. They have to. If they don't have those gaps between them, then you can't have saliva, which is the best cleaning agent any of us will ever have in our mouths, be able to travel into all the nooks and crannies. And saliva contains antibodies, like no mouthwash you buy. So it contains things that will actually help keep the bacterial balance in your mouth. There's no such thing as a sterile mouth. It is bacterial balance, like your gut. Good bacteria, bad bacteria. When the good bacteria is up and the bad bacteria is down, gut works perfectly. It's exactly the same in the mouth. Sterile mouth, not even in dead people. So we can forget about this sterile mouth thing. Am I cleaning my teeth? I'm getting food stuck. Don't eat. That's the answer to not getting food stuck. But if you're going to eat, you're going to get food stuck. But don't worry, you're going to be able to dislodge it if the engineered cleansing gaps are designed for easy cleaning, as you do, Carol, with your team. So let's start with the planning process. So we get all the data together. So where it's all in color is the intraoral scan. It's the camera that we use inside your mouth, and it gathers the position of the teeth. Where it's all yellow, so can you take the intraoral scan off so we can see the CBCT? We need to put the teeth back. Okay. This is all from the CT scan that we took. And we can actually merge the two, so we call this alignment. Alignment is one of the most important jobs in the entire process. So we have these 3 data sets. 2 of them are in one file format, and the CBCT is in another file format called DICOM, which is the global standard for all CT scans, and we need to convert that DICOM into another file format called an STL, which is stereolithographic file format. We need that because we can't design on anything other than an STL format. So we convert everything to STL format, and then we merge all the parts together. So add the intraoral scan on top, okay, and then take away the red bit, yeah, and then now we introduce the face scan. So zoom out. So there's our Gordon there in wonderful 3D. It's like a history lesson, isn't it, Gordon?
Yeah.
It's like staring back in time.
Yeah, true.
So that was Gordon's reality. We're using the retractor because we want to clearly see his teeth. I mean, we don't really need to use the retractor that much now because technology's got even better. But I also want to be staring at the pupils of his eyes. So I'm just going to draw some lines on this. So I'm just going to draw what we call the mid-pupillary line. So this is the line that bisects through the middle of the pupils. So pretty much everybody, we've got the correct plane when it comes to our pupils and our eyes. We use that line to look at what we want to achieve as a bite plane, which is around here somewhere, and we want that line and that line to be there or thereabouts within 10 degrees or so. Perfect. Is there any such thing as perfect? No, not on an asymmetric face. So asymmetry is standard, but this is our design methodology. And then, as a general rule, for men, for center lines, we follow the center of the nose because we know this about all us men. Our noses grow our whole life, so it's like the big honk we've got in the middle of the face. For women, we like to work to what we call the Cupid's bow, which is the area in the top lip, the lipstick line as I like to call it, the center point, and marry up the center lines on that. But again, that is also subjective depending on the anatomy we have left. So now we're going to go into some planning. So the first thing we do, the first step we do, is something called a wax up. This is a really important step. So that's what we highlight here in green. What we are using is we are using as much of Gordon's natural anatomy as possible because we know that the best engineer is nature. We know that. We know that when this skull develops, its dimensions, length, width, all kinds of stuff, we know that that's the same time that the teeth developed. So if we can find natural anatomy, not people who've had crowns done, because that's a distortion from natural anatomy, unless, of course, they work to this kind of wax up. If we can find anatomical landmarks that we can reference as part of the original state, then that's what we'll use, and then we do this thing called a wax up. It is to put back what should have been, or as close as damn it, with the anatomy we have left. The residual anatomy. Now remember, a lot of the anatomy that was there originally has been lost. So we can only work with what we've got left, which is why we call this calculating the optimal balance of compromises, and there's no such thing as perfect. There never will be. Now I know online you'll see pretty pictures on TikTok and they'll go, oh, it's like this. Yeah, well, that's anatomy dependent. And I can tell you, for the people we see, a lot of what you see on TikTok, turkey teeth-wise, is not possible because these people are like 25 years younger and they haven't lost as much anatomy. So we've just got to be realistic in what we do. So can we take off the face, please? Can we show this and just show the original teeth underneath, please? Just keep the jaws and then just fade out the green so we can see it against the old anatomy, please. Okay, so we can see that the green is aligned better than the original state. We have to, because we can't reproduce this. That involves micro changes in all kinds of jaws. Carol, can you take off the lower jaw and just show me the upper jaw in an occlusal view, please? Remove the lower completely. And the wax up on that. Okay. So the other thing that we can see is where we've set this up. This arch sits in something that we call the neutral zone. And the neutral zone is the area between the lip on the outside and where the tongue sits on the inside, and that is the ideal position. Now we can clearly see, for example, this is our own natural tooth here, and this tooth has drifted inwards over time, probably caused by his denture. That tooth is ever so slightly out. This tooth here is twisted. That tooth there is ever so slightly out. That is ever so slightly out. And it looks like it's really small movements. But tight against them on the outside and on the inside is the tongue. So the minute you have a little bit of movement one way or the other, and usually it's anything beyond 2 millimeters, muscle adaptation takes a lot longer. And we're going to talk more about muscle adaptation towards the end. That is the thing that's grossly underestimated by everybody. Muscle adaptation is king in all of this. It's not the teeth, it's the muscles. So we've done a wax up, which sits inside his original neutral zone that we've calculated. We also know it's going to look harmonious on the face. We also know it's going to give you the smile you want, which you have right now. Yes?
Yes.
Give us a grin. That one. That one. Right? And we also know that we're adding teeth where he hasn't had teeth for years. Now, when he takes his dentures out at night time when he goes to bed, for the 8 hours he's asleep, the tongue and the lip sit inside this space. So the minute I put the teeth back, how many times did you bite your tongue and your lips and your cheeks?
Yeah.
But you don't do it anymore a year later, do you?
No.
That's because the muscles have adapted. But in the beginning, it's normal.
Cheeks, yeah.
Because it has to have time to realize that it shouldn't have sat here in the first place. Because those teeth were extracted a long time ago, and now we've magically put them back in a matter of hours. The muscles won't adapt. They take months and months and months and months and months to adapt, and it's slow. And through that process, old habits die hard. The tongue and the cheek will want to move into the positions that it used to be in, and occasionally you'll bite your tongue or your cheek. It'll happen. Can we look at the lower jaw exactly the same format, please? Just remove the top. Yeah. So it's exactly the same. So you can see the new lower setup sits further forward than his old one, which immediately has an impact on his lip sitting here. So I know for a fact, Gordon, that in the beginning, when I did it, you were doing this.
Yeah.
Yeah. Why? Because your lip was like, wait a minute, this feels different. Yeah, of course it does. But I'm not putting it back there because we calculated that it's not stable. We calculated that it's far more stable here. And it's a question of the muscle on the outside, the lip adapting. But I also know that your tongue felt like the teeth had disappeared because it had to travel another 3 millimeters than it did before. So there's all this thing going on. And then but this is normal though. Every patient does it. They evaluate their mouth with the tongue. Of course they do. Yeah, but your tongue's not a diagnostic tool. Oh, it feels like it's massive. Yeah, it doesn't mean it is. It just feels that way, that's all. The clinical parameters are already dialed in at design, and there is a methodology towards it. For example, this thing's leaned over like the Leaning Tower of Pisa. That was a massive gap. Suddenly there's 2 teeth here and that vanishes. Of course the tongue's going to know it's different. Of course it's going to know it's different. And it's going to feel weird because it got used to this rubbish. Correct?
Correct.
And you were playing with it with your tongue. You can't help it. Even if you tell yourself, please don't do it. Your tongue's got a mind of its own. It has. And people talk about this thing, but I don't think people are understanding. There's this thing called muscle memory. And the muscle memory stretches all the way back to through the development ages, through puberty, when the adult skull was forming. And there will have been a time for almost all of you, not everybody, but almost all of you, where everything lined up perfectly. So we know that that memory is in there somewhere. I'll tell you who it's really, 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 really difficult for. It's for people who've always had crooked teeth or had missing teeth from a very early age. In fact, the patient who I know who struggled the most to adapt was a lady who had all her teeth out when she was 12. She went through the whole of puberty and her adult life wearing dentures. And then at 61, she decided to come and see me to have fixed teeth. She got fixed teeth. All clinical parameters were met. She couldn't adapt for 3 years. And then 3 years later, like that, one day she woke up and, yep, feels like me. But for 3 years, she was convinced that I should just put her back in dentures, which was destroying her jawbone. But then she didn't have any of her own natural teeth since the age of 12. Am I surprised that after 50 years, it was one hell of a change? But I knew clinically that she'd be much better off with fixed implant reconstruction because it wouldn't destroy what little bone she had left, because that's what the dentures were doing. They were just destroying bone daily. So we plan all of this, and then of course, one of these guys will wonderfully call you up and run through all of this to explain it to you and to get you in the headspace of, right, well, okay, you need to be mentally prepared for the adaptation. And any of you who've reached out to us and even spoken to my coordinators, they'll keep going on about prosthetics and adaptation, because that's what we do. We make prosthetics. What we don't make are teeth, or screwing teeth, or go in and have some teeth screwed in. That's not implants. An implant is not a tooth root. It has no nerve supply, it has no blood supply, it sits in no elastic pocket. That elastic pocket is called the periodontal ligament, and it's when you lose the periodontal ligament that you have periodontal disease. And we know how detrimental it is to lose that shock absorber called the periodontal ligament. So then we move on to our prosthetics. This is why we make our prosthetics with a titanium subframe and a polymer on top, because only the polymer gives us anything close to that elastic pocket that we lost. That gives a lot of you the problems you have, which is periodontal disease. Periodontal disease is the loss of the periodontal ligament. That elasticity goes, the bone goes, everything starts moving. The only thing that reproduces that elasticity, which is kind to the bone for us, is titanium PMMA. I have used every material under the sun quite extensively. I've been doing full jaw rehabilitation since 1999. I've done zirconia, I've done ceramics, I've used PEEK, which is a polymer that they use for spinal cages. I've used all kinds of materials. And I can tell you the one that is kindest for us, the results that we see at annual maintenance every single year, because what we're looking for when we see you every 12 months and we take those scans, when we look at the x-ray, we are looking at bone loss around the implant, and we just see virtually none. And that's what tells us that the mechanism, the complex, the implant bone prosthetic complex is working in harmony with the rest of the body. We just want to know it works, and we just want to know. And the PMMA itself is a fail-safe. If it's overloaded, and it can be because you've got no nerve supply in an implant, then I would much rather the prosthesis breaks, because I can replace that because it's above the biological tissue, than the implant breaks, which is below the biological tissue. Now, I've fished implants out. In fact, we remove implants daily on patients who've had implants done that just don't fit the strategy of what we're doing now. A broken implant is a nightmare to remove, but a broken prosthesis is easy to fix. We don't want broken implants because there's very invasive surgery involved in doing that. And you're not always guaranteed that the bone you have to remove to get the implant out will ever grow back. For me, it's too much of a risk. So for the foreseeable future, unless they produce bouncy zirconia, we're going to be using PMMA. We know that it's the first material that was used for full jaw rehabs. We know it was documented by Professor Brannemark from the 1960s. And it's still documented today. We know that every association, like the Brannemark Institute, like Nish Institute, say that the go-to workhorse is titanium PMMA. And we just work to those principles. We understand, you know, people talk about zirconia, it's wonderful. Zirconia, in the correct cases, can and should be used. But I just don't, because I'm nowhere near as comfortable for my patients long term with that as I am with titanium PMMA. Why? Because I used zirconia before I used the current configuration of titanium PMMA. It's what led me to use titanium PMMA. So I was using zirconia 15 years ago. It's not new. And it's a material, and it's like every biomaterial you use. There is no such thing as the perfect material. Everything has good and bad, and it's the balance of the compromises that we go for. So you have to understand how much thinking goes into just getting to the design stage and then deciding, okay, what is the strategy for the materials? What are all the things that could possibly go wrong for the patient. So what happens if somebody just trips and falls over and lands on their face? If it's just the PMMA that breaks, great, and it will, because it will be the first thing that breaks, because the shock will be absorbed by that. Easy to change. If the implants break, then it's surgery again. So it's bad enough you've had a fall, and now we have to go fishing bits of old screws out of your jawbone that's fused to the jawbone, which is a nightmare, which we don't want. So that's the thinking behind the planning side. So when you come for your FTA, when we ask you for the photographs and things like that, we're already thinking about this. We're already thinking about, okay, how do we set this person up so all the problems that they've had in the past are not repeated again in the future? One thing I can guarantee all of you is you'll never have toothache. You don't have teeth. It's different, right? So that's good. You can all have sugar. It's not good for your waistline or your diabetes, but you won't get rotten teeth. That you can do, right? So you've got all of these, and everything is a balance. But it all starts from original data. What are we starting with? What can we work with? And the other thing we know, how long have you been in my planning team, Carol?
2 years.
2 years. Have you ever seen two cases that are even remotely the same?
No.
Right, okay, so that's the other thing. Comparing, oh, mine's like this and mine's like that. Well, the clue is, look at your head. Your head's different to this person, so why would you expect what's in it to be exactly the same? So this individual variation thing is crucial, and not everybody responds or heals exactly the same way. Some people will respond brilliantly, some people will take a bit longer. But we just know that the biological processes are the same for everybody. If you are alive and you break your leg, and I put it back together and I wrap it in plaster, I just know you're going to heal. I just don't know exactly when, because it's different for everybody. There are so many variables. How many different medications are you on? What is the underlying medical conditions? What is your BMI? What is your blood pressure? What is this? What is that? And it's a combination of all of these things that determine how well you're going to get through the journey. And then the other thing I want to talk about, which is the sign-off. The sign-off does not mean that it's the end of your healing. Your healing and your remodeling of bone is permanent. My mum's implants have been in for over 40 years. I know for an absolute fact the bone around her implants, like the bone in every inch of her body, is permanently remodeling. Because that's how living works. It's like the skin on my arm. It's not the same as it was when I was 12. It's not the same as it was 3 weeks ago. It's permanently shedding and remodeling. That's what happens. We know this. So you have to understand that sign-off only means that we are through the surgical phase. Now it's just the body taking over and doing the rest. It doesn't mean, so when we say to you, go ahead and eat a steak. Yes, go ahead and eat a steak. But it's not the end of remodeling. Gum tissue. Gum tissue for almost everybody will close in full, completely, 3 weeks. But it's not the end of gum maturation. The gum is going to continue maturing for up to 12 months. And then it's going to remodel permanently for life. And it will fluctuate up and down. So one day it will feel like you've got a big gap, and the next day it will feel like the gap is gone. But that's just natural remodeling, because we are in a prosthetic state. The prosthetics, we designed the prosthetics with an engineered cleansing gap to a fluctuating base. That gap has to be there, because it's not really, as weird as this sounds, it's not you cleaning it that we're interested in. What we're interested in is for the 23 hours and 56 minutes that you don't stick a toothbrush in your mouth. Can the saliva get to these places? Because that is the real cleaner. Is it designed correctly so it doesn't encourage biofilm formation? And biofilm that creeps up under the gum. We're very confident before we send it out that it is designed to not encourage biofilm. Biofilm is what I worry about. Food, I don't really worry about. Just drink some tea. It'll just go away, right? And all of this thinking goes into the planning. And now you are 12 months, not even 12 months, 11 months down the line.
11 months, yeah.
Okay. When we did it, after a month and a half, you thought about it, didn't you?
Oh, yeah.
Today,
No, I'm not thinking about it. Unless I'm reminded.
Like now,
Yeah,
where I'm putting
well,
you on the spot and saying that's the rubbish
exactly.
you had.
But I'm not thinking about it. It became the part of me now. I don't think about it anymore, which for me is the greatest success of everything. I don't think about it.
How long into the journey are you, Christine? Christine, can you hear me? Christine, can Christine hear me? No? Can you hear me?
It'll be 2 years in June.
2 years in June, now we can hear you. Right, okay. Let's talk about
I
6
can
weeks
hear you.
after you had it done. Can you remember
I
that?
can. Yes.
Yeah, okay. Tell us about what 6 weeks after you had it done felt like. No, there's a delay.
I can help there if you want.
No? No,
I was just trying to. Can you hear me?
Can do it.
We can now. I think there's a
No,
lag.
it's not working.
I think that's the problem. These technical people have screwed up.
That's Paul.
Paul, how long are you into the journey?
4 months. Can you hear me?
4 months. Okay.
Yeah.
Tell me how weird 4 weeks felt like compared to today.
Yeah, weird. Tongue moving all over the place.
Right. Okay.
Yeah.
And what's changed?
I can still slightly feel the top jaw. Not much these days. Bottom jaw feels like it's been there forever.
Forever. Right.
Yeah, it does, yeah. Bottom jaw's amazing.
Yeah. So the muscles are the big things at play here. So
Yeah.
my friend, the cross-sectional head, can you zoom in? Can anybody zoom in on this? If you zoom in on that, we see that the vast majority of the mouth environment is the tongue. And then we've got the lip on the outside, and this little sliver here is the actual jawbone itself, and this little bit here is the tooth. So you can see how small it is compared to the muscles. The muscles recalibrating to this is adaptation. That's what it is. The bite issue, that's also dynamic. So the way you swing your jaw when you used to chew, like the way Gordon used to swing his jaw when he used to, I can tell from that photograph you probably chewed more on the right than you did on the left.
Yeah.
Yes, because you had more contact on the
Yep.
right than you did on the left. After we did his correction, his brain just kept doing that because it didn't work out yet that you've got all of these teeth. And now all of a sudden he's far more vertical, but it's taken months to readapt. That's not the teeth moving, that's the gum, that's the muscles and the joint recalibrating to the correct position because it hasn't had it for years. So understand that all of this goes into the thinking behind the planning. So when we send you a screenshot of an STL, or when you speak to any of these guys on the phone with the patient managers, it's about explaining to you the changes that we've made, things to expect moving forward. And we're going to be doing more and more and more of this. And part of what we've got going on here is we've got an AI division. So the AI is going to give you even more granular detail. Now, reading the AI detail will seem overwhelming, but it is based on clinical fact because this is an incredibly complex correction. And there's so many things at play here, not just the teeth. It's all the muscles around it, it's the psychology behind it, it's the emotion that goes with it, it's the fact that it's in the middle of your face and, you know, what are people staring at and is it right for all that stuff. It's all there. So the planning is the cornerstone of everything. We get the plan right, then we've got a high chance that the execution will go correct. But we're going to talk about execution on another one of
Meeting.
these. On another meeting, yes. But we'll stick with the planning. So I hope you get an insight into how we work the plan. How many on your team now?
6.
6. So we've got 6 people that work on this full time. How many do we have in the other planning team? 12? So 18 in total. And we've got AI alignment now. And we've got AI wax up as well.
Yes.
Right, so don't underestimate that it's not me sitting in the corner going, well, that looks all right. There's a little bit, there's a lot more technical stuff that goes into it. But from the patient's point of view, just getting their head around, and they shouldn't start the journey if they're not prepared for the adaptive phase. Just shouldn't do it. If you think that you're just going to wake up the next day and everything's just going to you're nowhere near mentally ready. You haven't done enough homework. You haven't studied it enough. So, just wanted to let you know on that. So, Q&A time. Ask me whatever you like. Or any of these guys.
Yeah. Shall I?
Yes, fire away.
Question from Julie.
Yeah.
She would
Hello,
like to
Julie.
know. Hi, Julie. Vijay, are you looking into new materials for the plugs that cover the screws as they come out and stain badly?
Yep. So the plugs for the screws is the bane of my life because the plugs dimensions we're always working to. We can't get plugs. We need a plug that's going to stay in, but we also need a plug that we can easily take out if we need to. It's a bit like a manhole cover on a road, but it's easy on a road because it's working with gravity and it's bloody heavy. In the mouth, because you're chewing, things are trying to pull it out all the time. All it is a silicone that we use, and any materials like silicones, we can't use really anything other than silicones and polymers. They will always degenerate with time. Now, if the plug is lost, other than it drives your tongue crazy, there is zero detriment to the implant below. And it's not just me, it's everybody worldwide. We cannot overcome this problem. And if you do enough of these, you learn over time that it's going to happen in some people, and in other people, it's not going to happen. Some people are going to be bothered by it, other people aren't going to be bothered by it. But if you're asking me, are there new materials coming in the future? Not that I'm aware of, but trust me, if there's one nerd on this planet who's permanently looking, it's me. Thanks.
Thank you, Vijay. Question from Magnus. Week 3, my prosthetic has came loose at the back. Is this normal? I have appointment with 21D, but what has caused this?
If your prosthetic has come loose at the back and you're not in any pain, then the prosthetic itself is held to the bar with a connecting screw. The connecting screw is a fail-safe that if you catch it or knock it in an axis that you're not supposed to, before you damage the implants, the screw will come loose. But I'm glad to hear that you're already booked in to see us.
Yes, tomorrow.
And they'll just
on
tighten
Monday.
it up. It'll take 2 minutes to do. It doesn't involve any pain or drilling or anything like that. It's a screw. So we'll find out tomorrow when we see you. But I really wouldn't worry about it. We've got screws in the mechanism that are there as fail-safes. For the same reason that I said before, implants have no nerve supply. So you need something to give before there's damage to the implant. So if it's going loose a bit and you have to come in and we have to tighten it up, but there's no damage to your implants, we're still winning.
Okay, thank you, Vijay. What does it mean when you say that implant failed?
Okay, I hate this term, implant failed. This comes from dentists, okay? So an implant is just a dead titanium screw. What we talk about is the integration of human bone to the implant itself, okay? What they mean by implant failure, true implant failure, is when an implant breaks. But if the bone lets go of the implant because it doesn't want to integrate or disease or anything like that, it's actually called a failure of osseointegration. That's what it means, if the implant lets it go. And usually, there's only 2 times that it happens. Either it happens very early, before osseointegration happens, for all kinds of reasons. Overcompression of the bone, lack of blood supply in the local area, these can all happen. We can't measure the blood supply in the bone using a CT scan. Nobody on earth can, right? And it can happen, but it's incredibly rare. And then there's late failure. Late failure, when somebody presents 5 years after we've had it done and we've got lots of evidence that it's been really stable, in my experience, almost always, it's one of 2 things. The main one being that their health has suffered dramatically, or there's something underlying systemic disease that definitely needs to be investigated, and something is causing the body not to be in optimal health. And the second one, which I've read about, is there are certain types of titanium used for implants. So there's type 2, type 4, type 5, and in type 5 that there's subtypes. There's certain types of titanium that are used, particularly alloyed titaniums, which I have used in the past, that in some people, they can have a spontaneous loss of integration. Now, I can tell you the implants we use is type 4, which is defined as pure titanium, so there's no alloy materials in it at all. But even that is incredibly rare. So the main reason for late failure is systemic health loss. The main reason for early failure is something local in the mouth. But the thing about implants, which is different to teeth, is you can put an implant back almost into the same hole if you let the bone heal for a few months and then just go straight back in. Something you definitely can't do with teeth. And the reason it works is because when we put an implant in, it's a bit like a fracture. So we know that when we break bone and we put it back together, the bone that forms is new, stronger bone than was there before. That is the whole principle of fracture healing. So if you had 4 implants and you lost one of them, which I know maybe 1 or 2 of you on here, it's happened. So long as the prosthetic is stable while we wait for the area to heal, or we can put another implant back into another site that we can use, there is no actual failure. You are just in a transitionary state to a new reality, but you've still got fixed prosthetics. True failure is, and I hate the word failure, I prefer the word interim failure until there's another solution. Because it's really important for us anyway, for me, to find a solution for the patient, but it isn't the end of anything. It's very different to teeth. When you take a tooth out, that's the end of that tooth ever being there again. But if you lose an implant, it's not the end. You can always re-implant and sometimes probably back into exactly the same site if you allow new bone to form in that area. Because it's the bone that's doing the magic, not the implant. The implant is just a dead screw. So the use of the word implant failure, for me, is when an implant breaks. Losing bone integration is a biological matter, and it should be referred to as loss of integration, not implant failure. Hope that helps.
Thank you. Question from Yasin. My question is about bone loss over time. Is it likely to get worse, and will it affect LTP bite over time?
Nope. So the definite thing that won't, unless your implants move, ever, and if your implants move, that's an issue. Unless your implants move, your bite will be stable, other than wear. Wear is normal. Teeth are like tires on a car. My own teeth, my natural teeth, have worn since I was 21. It has to happen, as is every joint in my body, because of movement. It's going to happen. Then we have something called physiological wear, which is within parameters which are okay to deal with. And then we have pathological wear, which is far more than what should happen on an annual basis. That's what we screen when we see you. Bone loss, on the other hand, there's only 2 reasons that bone loss will happen around implants. Number 1 reason is disease. And it's easy to spot disease on implants because you'll see one of 3 things. Blood, bleeding, aggressive, and obviously not by testing it, by scrubbing it with, a Brillo pad or something like that, because everything will bleed. Just light contact will just make everything bleed, so that's one sign, and that's an early sign. The later sign is pus. So if you press the gum, you will get pus coming out and you get a foul taste in the mouth. That is definitely active disease around the implant, but it still doesn't mean the end of the implant. And the third sign is mobility, where the whole lot moves, not the prosthesis, the actual implant with the prosthesis attached. So the implant and the prosthesis are tightly attached and the whole thing moves back and forth. Those are the 3 things. So I wouldn't be that paranoid, because the clinical literature says that if the engineered cleansing gap is in place, the chances of you having this are so low, you're in the low single digits chances of having it. The main thing, the advice I give to all patients, let's be realistic, we're all getting older. We need to take better care of our health. And if the health is optimal, why should the bone shrink? I think the confusion is people thinking, right, well, I had periodontal disease before. Can I have periodontal disease again? No, for a simple reason. Periodont refers to around a tooth. So it's a very specific disease that is only happens around teeth. So a simple example is somebody who's had all their teeth removed and wears a denture, they don't lose the bone because of periodontal disease. They lose the bone because the denture is like wearing a head vice on your head. It just keeps squeezing the bone so it shrinks away. It's not a disease mechanism, it's a compression mechanism. With implants, you get another condition called peri-implantitis. And the word itis, when you add it to the end, is an inflammatory state. It's inflamed because it's not cleansable, which is why I keep going on about the engineered cleansing. I mean, I drive this lot crazy because all I'm screaming at them is, show me the engineered cleansing space. I don't care about how pretty it looks before I care about the engineered cleansing space, because the pretty will be short-lived if saliva can't clean the critical interfaces that you can't reach anyway because they're below the gum. So I need the engineered cleansing space so saliva can get up there, because I know something. None of you can get up to the bone level where the implants are, and you never should try either. There's no gadget for it before anybody asks me. There's no such gadget. So it's really important that you understand why I keep going on and on and on and on about this, what you call the gap that food's getting stuck in, what I call the mandatory engineering cleansing space, that if you want your implants to be in you as long as they've been in my mum, you need that engineered cleansing gap. She has a 5 millimeter, half a centimeter engineered cleansing gap. Main reason being she's got arthritis. She can't really brush too well. Even with an electric, it's difficult for her to grip, but she is 85. You know, I have to take these things into account. So I know that I need to engineer in as much help for her body as she ages as I possibly can. And none of us are getting any younger, so the engineered cleansing gap from me is mandatory.
Thank you, Vijay. What type of sedation do you offer, and at what stage is it given to the patient? I have a severe dental phobia and need medication just to see a dentist.
There's phobia, which needs, it's a psychological condition that needs to be treated, and there's anxiety. Oral sedation is my preferred method for two reasons. Number one, it's incredibly safe. Right? IV sedation is safe, but it just prolongs surgery in our experience, which is why we don't do it here. There are other providers that do it, but none of them are general anesthesia, which is put me to sleep. It just doesn't happen in this country. I've seen it in other countries where they do it. I don't agree with it. I don't like the fact that a patient's intubated and we're in control of their airway. It just complicates things. Oral sedation, which is temazepam, we know is incredibly safe, and all the clinicians are incredibly proficient in using it. And it's more, I made a video talking about sedation versus anesthesia. The sedation part is to deal with the anxiety level. Now, if I had £1 for every time I heard from a patient that I treated, I'm so scared of dentists I can't go through with it, I'd be a multi-millionaire. Because they all say that to me, because they've probably already been through horrific experiences to get to us in the first place. And it's not to, it could be to do with the dentist, but you know, it's not to do with the dentist, it's to do what happens up here. And the sedative just takes the edge off it. And I used to call them la-la pills because they would behave like I behaved after 2 glasses of red wine, but I'm a lightweight. You know, I can't take more than 2 glasses of red wine, but it just puts you in that mind where you're not as focused on the thing that's making you anxious. And we treat, I don't know, 150, 200 people a month. And this is something we hear every day. And this is something we hear right from the beginning of the journey. For me, 10 to 20 milligrams of temazepam is a wonderful thing if medically you can take it. Now, there are people who are on drugs that medically it's dangerous for them to have, which our GP will point out. And it will be a no, because your safety comes first. Number one, we're just not negotiating that, and we know better than you on that one. I want it. Well, if you have it, you're going to die, so there's no chance we're doing it. It's just end of the discussion. There's no way we're going to change our mind on that one. The vast majority of people, even the most anxious ones I've known over the years, 20 milligrams, up to 20 milligrams, and we get them through it. We do. It's a collaborative thing. You know, it's important for the team that you're as calm as you can be. It's important for you that you're as calm as you can be. And we're trying to get you through something that we've already established you definitely need. Do I know of a general anaesthesia service in the United Kingdom that will do full mouth rehab? Not as far as I'm aware. I keep being told that apparently this is available somewhere on the NHS. I've just never known a single person being treated with it. Maybe I just don't read enough. I don't know. General anaesthesia must only ever be used, in my view, where you've got access to an anaesthetist and an ICU just in case anything goes wrong. That's my personal view on the subject. Here, we are not a hospital. We are a clinic at scale that just does this day in, day out. And in our experience, the vast majority of our patients either don't need it or 10 to 20 milligrams, and almost always 10 milligrams is enough and we can get them through it. I think the best thing for you is to speak to someone like Christine or Paul. These are people who've been through the journey. Christine, you're a particularly good one for this, aren't you? Aren't
Yes.
you? What did
Yes.
you tell us? What did you tell us in the beginning?
I was so scared. I just didn't think I better go ahead with it because I was so scared. All of my past experiences had been awful, really awful.
Yep,
But I was in such a bad way that I knew I had to do something.
yep, yep. So what got you through it then?
You lot, really. The girls, when I first contacted them, they were so understanding. I didn't think anybody would be understanding.
Yeah, but why
but
would
they
you think
were.
that? Why would you think we wouldn't be understanding?
Because all my life, whenever I'd plucked up the courage to go and see a dentist because I was in pain, I got eye rolling, I got tutting, I got, well, if you'd looked after them better, I got, oops, I was just made to feel like it was all my fault.
And how long were you convinced that there's no way you could get through this?
Oh God, I've been looking for ages. And my tipping point was my front tooth got knocked out.
Right.
And that was it. I thought I either apply to join the cast of Wicked or I get something done.
Okay, and then let's talk about the actual day itself. You turn up, you're a nervous wreck, you've got all kinds going through your mind.
Yeah,
We
I
give
didn't
you,
speak.
we gave you temazepam, didn't we?
You did give me temazepam, but
One
to
or
be
two?
honest with you, you gave me one, I think.
Right,
I was, to be honest, not much went in that day,
right.
but I
Zoning
remember
out.
feeling more calm than I thought I was going to.
Yeah, there's a lot of
but I was-
self-hypnosis that happens here as well, you know. There's a lot of zoning out, I
kind of-
agree.
Resigned. I mean, I feel such an idiot now. I turned around to my husband and said, if anything happens, if this is it, it's been a blast, you know, I'm off now. Because I really thought, I'm going to be the one that something happens to. I'm going to, I don't know what I thought.
Yeah, but everybody thinks that. That's the weird,
Yeah.
because it's such an incredibly personal journey, and they just think that they're the worst we've ever seen. They're the most, they're the ones that with the highest anxiety that we've never seen. I've been around for decades, man, and that's so not true.
But we've been told for decades that we're the worst they've ever seen. We've been made
Not
to feel
for
like
us.
that. It's very hard. No. That's
Not
that's
for
the whole
us.
that's the whole thing. You guys are totally different.
Okay, but I think the person who asked this question, in my view, should really talk to one of you guys rather than talking
Anytime.
to us. Because
Anytime.
I know that I know your story, Christine. We've spoken about it a few times. I know
Yeah.
how much it took for you to just even send photos in, let alone turn up for a clinical assessment. Right?
3
That's how
months.
petrified you were,
Yeah.
you know.
3 months to take the photos.
3 months
You
to
waited.
take photos, to send them in. Right, okay. So
Yeah.
now I would
And
call that-
no one hassled me
Yeah.
I thought I was going to get lots of like, have you done it yet? Have you done it yet? No one.
No,
They
no, no.
let me sit in that feeling for a while, which is
Yeah.
I needed to.
Yeah, because ultimately it's you that makes the journey, and you have to be ready to make that journey. You know, which is
Yeah.
why I really appreciate the fact that you guys are here, because actually you guys are the best person to talk to this person, not somebody who hasn't had it done, like Carol, like me. Okay, maybe Gordon here, you could happily talk to people now, can't you?
Yes.
Were you anxiety free? I found out something that you didn't share with me. Even though you get to talk to me on a daily basis, you decided to turn to Claudia for advice and not me, which I was quite upset about, because you were literally in the next office.
Yeah, yeah. But Claudia was a patient,
Yes.
and she's the one that can tell me actually what she went through, and
So you already judged
felt-
me.
I felt comfortable.
You already judged me and went,
Talking.
okay, he's the guy that came up with it, but I'm not asking him. What the hell does he know? Let's ask his patient from 10 years ago.
Yeah,
Right, nice,
Yeah.
nice.
that's what's happened.
It proves the point. For his anxiety management, it wasn't the pill, it was Claudia. You understand? And maybe this person could benefit from having a chat with you guys. There's no pressure. But then the number of times I've heard, I don't think I could get through it, and the number of people that have actually gotten through it, this is the anesthesia itself with the local anesthetic, apart from the needles going in. Oh, God, there's no one I know that hates needles more than I do. Right? I've yet to meet a human being that goes, oh, needles, great. You know, that just never happens. We get all of that. But that is the anesthesia. That is the thing that guarantees that there is no pain. That thing. The sedative is about here and just calming that down a bit, because it's telling you stuff that isn't based in reality. It might be based on past experiences, but it's definitely not based on what we do here. So the other thing, the other post I keep reading about is people keep posting on there going, oh my God, they took out like 17 teeth in like 5 minutes. Yeah, we do this every day. It's normal, because that's what we do. There are techniques on how to do this at that speed, at that efficiency, that painlessly. It's very
25.
different to past experiences. And my advice to the person, if this anxiety, this deep-rooted anxiety is coming from negative experiences, then you should speak to people who are on the other side, who lived those negative experiences and are now on this side, and help to quantify it a bit. But one thing we can't do is provide general anesthesia. That will never happen. I am the guy that drew the line under IV sedation, because I know that surgery takes longer, and not by a little bit, by a lot. As a surgeon, do I want to keep a patient cut open for 1 minute longer than they should be? Absolutely not. Absolutely. There are so many risks associated with prolonging surgery, even by a minute. And call me a fussy bugger. I am the reason that there is no IV sedation in this company. It's all my fault. Happy to own it. Won't change my mind. Temazepam, in 20 odd years, pretty much everybody I treated, have this pill. I'll come and look at you again in 10 minutes. And when I see you looking spaced out, then we're going in there and it'll get done. Works for me. Everyone's safe. Happy with that. So I hope it helps. Speak to these guys here.
Next question from Michelle. I have a high smile line showing my natural gums.
Yep.
I was told my case is complex. Can you explain how the cleansing gap will not show when I smile?
Good question. Bring Gordon's. The problem is it's a retracted view. Okay. When you have a high smile line, normally by definition, what we mean by a high smile line is somebody smiling where we see 100% of the tooth up to the neck, and then we see at least 3 millimeters of the gum above that. Now, my cutoff point is when I get to 6-7 millimeters of gum. When I get to about 7 millimeters of gum, I'm going, okay, this is going to get difficult, because I'm dealing with a finite amount of space. When I'm dealing with people who've got 3, 4, 5 millimeters of gum. We plan the bone cut higher so that we can hide that transition loan above the highest movement of the gum itself. So when you come in for assessment, if you and you'll have come in for assessment if we've already given you a plan, we will have analyzed where we can put that, because I think I know who this is because I'm the one that looked at your case. I'm not going to mention any names, Michelle. It's like the other case that I posted where I went through the analytics where you saw me transform that person from having what was defined as a high smile line. And what had actually happened was, yes, they had a bit of a high smile line, but actually their own natural teeth had drifted downwards. So it looked like there was a lot of gum show. So we can do some clever engineering to hide that transition zone above. But one thing we will be doing is we will be positioning these teeth higher up. So instead of showing 100% of the tooth and 3 millimeters of the gum, imagine I just pick this whole lot up and move it up that way. It'll change the smile profile definitely. Why? Because you've lived that way probably your entire life, and I'm changing the smile profile. I have to. What I can't do is just take the old teeth out and just screw one into each socket back and then line them up neatly. No one on this planet can do that. It's just not possible. The other reason, because I think I remember the case, the way the bite is it's so deep that it's traumatic. I can't allow that to continue, because if I reproduce that with implants, where the lower teeth are hitting the backs high up on the top teeth, I could make these implants and teeth out of steel, and you'll still break them. So I need to put it into a state that it's not going to break. So I'm going to deal with the high lip line by repositioning everything upwards so that the smile profile changes. Adaptation is going to be difficult for you. Definitely, adaptation is going to be difficult. But then at a clinical level, when we analyze, there are no alternatives other than either live with that or accept the fact that you're going to end up in dentures. And for me, dentures would be much worse. And living with it, nothing's going to get better. Everything's just going to get worse. So I think I remember the case.
Yeah,
we remember the
discussed it,
case,
yeah.
don't we? I remember the case. Don't worry, we're not going to mention any names, Michelle. But thanks for the question. I hope it helps.
Thank you, Vijay.
No problem.
Next question. I've noticed my mouth produces saliva a lot since
Yep.
surgery a year ago. Is this normal?
Yep. So it's called hypersalivation. It probably happens in about 3 to 5% of patients. You cannot predict it at all. It's part of the adaptive process. When that saliva is being produced, you should be delighted because the saliva is the best cleaning agent that we've got. But the reason it's being produced is the brain still thinks the prosthetics is food. So when you introduce a foreign object into the mouth, salivation happens because it thinks that it's going to digest it. Is it detrimental? No. Could it be annoying? Probably. Is it doing good for your implants? Absolutely. I would prefer you were all hypersalivators. That's what, me personally, I'd love that, because it would greatly take away my problems. In fact, the vast majority of people suffer with the opposite problem. And it's not because of the implants or the prosthetics, it's because of aging. Because one of the known things about aging is mouth becomes drier. So you've got the best problem in the world. I wish I had it. You'll have great fresh breath, that I know. So it's not a problem, and I don't know when it's going to go away, and if it ever will. But in my experience, have I ever known anyone in 27 years hypersalivate permanently? Nope. The furthest out I've known it is 3 years. Nothing beyond that. It's just the brain getting used to a prosthetic state. It still thinks it's food. I'd be curious, though, if it's happening all the time or if the frequency is fluctuating. Sometimes it does, sometimes it doesn't. I don't know. But in my experience, I've never known anyone have it permanently, ever.
I have Sjogren syndrome causes extremely dry mouth. Would having
Opposite.
implants make this worse
No.
due to lack of saliva?
Nope. So Sjogren syndrome is a known syndrome, dry mouth. We call it dry mouth syndrome, right? When you have teeth, you are given saliva substitutes to hydrate the mouth. It's dry mouth, not arid dry mouth, as in no saliva. There's just nowhere near as much. When we do implants on these patients, the design of the prosthetic and the emergence from the gum is even more critical. So in these patients' cases, we might increase the cleansing gap. So to get whatever little saliva we can get and fluids bathing the connections that connect it to the implants below the gum. So it's one of the things that at your clinical assessment and before your clinical assessment, when you fill in your medical history and we know about it, the planning guys will go, someone with Sjogren's syndrome. I've treated plenty of patients with Sjogren's syndrome. They're fine. We know that the lack of saliva accelerates things like tooth decay in teeth because the neutralizing effect of saliva isn't there for sugar, but we don't have to worry about tooth decay. So we're not that worried. It's a bit more robust, the mechanism. Dry mouth is dry mouth. For me, the answer to all these patients is sip water permanently, keep the mouth wet and hydrated permanently. It's the easiest thing to do. All this other stuff, artificial saliva. Yeah, I know it exists, but am I a fan? Not really, just sip water.
Thank you. A question from Joanne. How long could implant last? I'm only 50.
My mum's 85. She's had hers for 41 years this year. As far as I'm concerned, I was saying this to Christine, from all the clinical literature I've read, decades, easily, decades and decades. And like I told you, late failure happens when health deteriorates, not physiological aging, getting a bit old, getting a bit frail, not that, like total liver failure. That kind of stuff. It's something really catastrophic that could have an effect at bone level inside the mouth. But if you're in generally good health, I was saying to Christine earlier, I'm going to be very famous with archaeologists. You know, when they dig Christine up 10,000 years from now, my implants are still there. I'll be delighted. So we are engineering you for a lifetime. Then it's over to you, because we have to, apparently we can't lock you up in basements and feed you under the door. You're apparently free to go after the annual assessment. So you just need to make sure for 364 days that you're taking care of them properly, you know. And for me, like my mum does, she takes care of them. She doesn't do anything special. It's 4 minutes a day, 2 minutes in the morning, 2 minutes in the evening. She just gets on with her day. They're still there. And what she has is 40-year-old technology. 40, I mean, we didn't even have mobile phones when she got her implants. That's how old her implants are. So that is how archaic what she has is compared to what you all have. I mean, the engineering standards today compared to what we were doing 40 years ago, it's through the roof.
Get black and white TV then.
Yeah, exactly. I remember my TV. It took 3 people to carry it. And it was only a 19-inch.
Right. Question from Rianne. If the LTP breaks, how quickly can it be fixed?
Which bit of the LTP? If the veneer breaks.
Veneer, I guess.
So I'm going to be doing a podcast about the next generation of LTPs, but that's a discussion for a different day. The veneer itself, replacement, we already have the digital file. So if you went through the pathway where you went from deprogrammer to LTP, then what would happen is we would switch you to the deprogrammer, take your LTP back, switch the veneer. I think I said somewhere else on another post, I think I've seen 2 titanium bars break in 27 years, and both of them were my fault, because I could identify that the accuracy of my impression taking wasn't good enough, and I introduced the titanium bar with tension in it. That virtually never happens now because we're using digital data, which is the most accurate data you can get. So I don't expect your bar to break. I mean, I'll be shocked if your bar broke. No one will be more shocked than me. Veneer breaking, the veneer is a fail-safe. So if you have the deprogrammers, we'll switch you. If you don't have the deprogrammers, we already have your digital files. And if we have your digital files, then we should be able to switch it in the mouth if we've got 24 hours to get it to you. But again, the first thing we're analyzing is why it broke, not the fact it's broken, because we're engineering them to work with a normal human diet, apples, steaks, all that kind of stuff. So we need to analyze why it broke. But replacing the veneer, it's engineering. It's like changing tires on a car. It's really a question of how quickly you can get to Halfords and whether we've got the tire. That's all it is. It's that kind of a mindset. So it isn't this protracted, you're with no teeth for 4 weeks or anything like this. None of that, no. It's days, hours, hopefully. Go on.
Okay, thank you. Question from Kirsty. I should have had my surgery in February, but we had to postpone till June. Will the data from my FCA in November 25 still be usable, or would you expect there to be any changes due to it being a longer time scale?
No. So we know from the data that we took, certain things will never move in your anatomy. Like, for example, the reference points of where the nerves are, that won't change. Your teeth might move a bit. That's okay. We're not really working with them anyway. The bone won't. So the only bone loss that I would expect between February and June, even in the most active disease, 1 millimetre. So yes, the data will be fine, and I'm assuming that we delayed the surgery on medical grounds, so that takes priority over anything in the mouth. So unless, because that's more concerning. If there's a medical issue that we need to deal with first, we need that to be dealt with. But the data itself, I mean, we've had a patient from a year ago or a year and a half ago, and one of the things we do when we take the scans is we see how likely things are to move, and if they're not likely to move and affect us being able to design guides, because these guys factor in the amount of time from the FCA to the surgery. It's on an individual basis, but I'd say at least 80% of patients, we don't need a second data set, and especially for 4 months, really. I don't expect anything to change, really.
Maybe we should wrap it up, but I wanted to read something from Claudia.
Our Claudia.
Yeah,
You had to step in, didn't you, Claudia?
yeah, she had to do it. So to Vijay and the 21D team, on behalf of all of us, your patients, we want to say thank you truly and sincerely. From the very beginning, your transparency has meant everything. The time you take to educate, explain, and speak honestly transform what could feel overwhelming into something clear and manageable. Because of that clarity, we are able to move forward with confidence rather than fear. Your openness replaces uncertainty with reassurance, and your communication builds real trust. We don't just feel treated, we feel cared for, respected, and supported throughout the entire journey. What you give goes far beyond dentistry. You restore self-belief, you rebuild confidence, and you give people the courage to smile again, not just with their mouths, but with their whole selves. Thank you, Vijay, and the entire 21D team, for your professionalism, integrity, and the life-changing work you do every day. Our smiles are a reflection of your dedication, and we are forever grateful. Claudia.
Thank you, Claudia. Hashim, can you ban her from all future lives, please, so she can't send stuff like this in ever again? Okay, I'm not a guy that does well with this kind of stuff.
I know you know, that's why I'm reading it.
Okay, but you have to... Seriously, you've got to share this with me afterwards. Right?
I have to, because she would be really upset if I haven't read that.
Claudia, you know full well that I am a nerd who has no life other than to think about this 24 hours a day. I'm obsessed with this stuff, and in the process of me being a grade A nerd, I get to help people who are suffering and get them through this journey that I know no human being in their right mind would be looking forward to. I'm also an educator, okay? It's really important for me that the people who are going to think about going through this journey get this information in a way that's digestible and understandable for them. You know, the science itself is so complex, and there's so much. How much individual variation do we deal with every single day on every single patient?
A lot.
And you've been here 2 years, and still you're going, look at this one. You know, but it is so important, in my view, for people to understand this journey for what it actually is. It is an orthopedic correction of the mouth. Be under no illusion. I think one of the things that's always bothered me is how normal everybody talks about hip replacements. Like, oh, I'm having a hip replacement in 3 weeks. Oh, are you really? And yet nobody talks about this like it is that. It's like so much more to it. There's so much more emotion, and there's so much more, oh, is this right? Is that right? Is the other right? The body will tell us if it's not right. You know, the body will just go, nope, don't like this. Here you go, have it back. But if it's still there, trust me, your body likes it. Just, and it's, this bit has always been important to me, because when I used to work chairside, when I could see them coming in through the door. And I'm watching these grown adults walk through the door in a childlike state of fear. And my first job is to help them overcome that fear by giving them narrative and explanation that quantifies it and goes, oh, it's not just me. No, there's millions of people like this. It's not just you. Everybody's petrified. Everybody I treat has got a knackered mouth. Otherwise, why are they coming to see me? So it's not like I'm sat here and, you know, you're the worst I've ever seen. There's no such thing. But I know how important it is in the decision-making process, because it's really an investment in you. It's really you deciding what you want for you. My job, my team's job, our job is to give you the tools that help you make that decision. Whatever that decision is. I'm going to have it done, I'm not going to have it done. I'm going to have it done, but not with 21D, with those guys over there. With the best will in the world. I can't treat everybody that needs this. But I think what's important to me and my team is that everybody that needs this at least has some base level information to base their decision making on. And I'm just the kind of nerd who can't help himself. You know me, you know what I'm like. You sit in the room next to me. You sit in the room next to me. I'm a bloody nightmare. And it's pathological, because I love it. I love sitting here, and I love seeing the fact that Paul and Christine started off as patients, and now they're part of the team. I love the I love this. I can't get enough of it. So thank you very much, Claudia, but definitely ban her from the next lives, please. Definitely.
Well, at the risk of being banned as well,
Yeah.
you should know that it's not just our lives that you change. I did so much last year that included people I haven't seen for years and brought joy to their lives. I babysat my friend's children for her so they could have a week together on their own. I would never have done all the things I did last year if it hadn't been for these teeth. Because my confidence is through the roof. I feel like I can do anything.
For me, I remember reading this a very long time ago. People don't know this about me. I didn't actually want to do dentistry. I only did dentistry to shut my dad up. And I managed to shut him up. And the great thing was, I came into it, I discovered this thing called implants, and I absolutely fell in love with it. It wasn't what I was expecting. It wasn't what I was expecting to do with my life. I'm a nerd. I'm a mathematics nerd. Everything for me is a calculation. But then I learnt about the unquantifiable. I didn't fix their teeth. I made them happy. And they would express that in ways that overwhelmed me. That was my payback. My payback was to watch them blossoming. My payback was to see them every year, because I had a year break from when I last saw them, and I'm watching them evolve in front of my eyes. They wouldn't see it because they're staring at themselves every single day. And it gives me a huge sense of satisfaction to see this. So I have an incredibly selfish reason to do this. It's my drug of choice. I really get a kick out of watching you all beaming and being happy and just getting on with your lives, just getting back on track, not living, you know, isolated anymore, not running off to the bathroom so nobody sees you fiddling with your dentures. Just normal stuff. I consider having a smile on your face to be a basic of human existence. We have no other way as a species to share our inner joy with others than to smile at people. And when that's gone, a part of you's gone. And I'm really glad that me and my team can give people that back. I don't think I'll ever stop being glad. I tried retirement. It was shit. I'm not doing it again. Right? I was really bored. Right? Because, you know, there's only so much cooking and gardening you can do every day before you're like, there's got to be something else. So I came back. And I love it even more. That's what's frightening now. Now I'm like super nerd on steroids. I've just gone into overdrive. I'm traveling the world looking for bits to bring back so I can do stuff, you know? So, yeah, I don't know. This is all a bit... I wanted to be like Banksy. I wanted to be, don't stare at me, stare at my art. But clearly that's not going to happen to me in this life. But thank you all very much for that anyway. Are we done? Yeah. Tune in again, folks. Thank you all. Cheers. Bye.